welcome to this Medtronic sponsored session from EuroPCR 2021. My name is Darren Mylett. I'm an interventional cardiologist in Galway in Ireland, and I'm joined for this session entitled Is Cusp Overlap the Standard of Care by Dr. Doug Fraser, an interventional cardiologist from Manchester in the United Kingdom, and Steve Yakubov, who is an interventional cardiologist in Columbus, Ohio in the US. Thank you for joining me, guys.
Thank you, Darren.
Steve, I might start with you. So tell us briefly, what is the cusp overlap technique?
Cusp overlap technique is a technique to deploy TAVR valves. So it's being widely adopted, especially for self-expanding valves. And what we typically do is try to get all the cusps in the same plane, but the deployment of the valve actually occurs where the left and the right cusps are overlapped, usually in an areocaudal view.
And tell me about the advantages of using this particular technique, Steve, versus the traditional coplanar view, which was typically an LAO cranial view.
What we believe is that the cusp overlap technique can get the non-coronary cusp isolated so that you could deploy the self-expanding valve, especially at the proper depth, so that we don't interfere with the conduction system of at the annular level. So I don't believe that you could isolate the non-coronary cusp any better than using this technique.
Okay, so the idea of this technique really is to implant at a depth that you believe is appropriate, your target depth, without parallax, and therefore to try and reduce pacemaker rates. So Steve, you've recently been conducting a clinical study sponsored by Medtronic on this particular topic, the Optimize Pro study, and I believe you have published some data recently. Can you tell us a little bit about that? Share some data with us?
Absolutely, thank you. So we've conducted the Optimize Pro clinical trial, and we're still in the process of the trial, but we're able to demonstrate what the first 100 patients are like. And this is a test of the REO cusp overlap technique to decrease the amount of pacemakers. It also tests a post-procedural algorithm for evaluating conduction disturbances, so who actually will need a pacemaker or not. So we're going to report the 30-day outcomes at the SCAI meeting. These are looking at mortality, disabling stroke, but especially permanent pacemaker rates. And as you can see, we're able to decrease the number of pacemaker rates into single digits in these first 100 patients. And again, this is mainly teaching many of these sites how to do the procedure. Median time to discharge is 1 day, so virtually all the patients go home the next day. Even if they have some sort of conduction disturbance, it can be followed with a monitor as an outpatient. And even though we're trying to implant at the proper depth of the non-coronary cusp, which may be a little bit higher than most people are used to, we have not seen pop-outs or a need for a second valve. The hemodynamic performance, as we see with typical self-expanding valves, is excellent. And the amount of aortic insufficiency we see, even though we're a little bit higher, has been outstanding. Nobody has more than mild paravalvular leak at the end of these procedures. And our data in the clinical trial is echoing what is happening in the TVT registry. As you can see in the TVT registry over time, as many sites are adopting this technique, which we believe is implicit in this drop in pacemaker rates across the country, is that you're seeing the cusp overlap technique be important in decreasing pacemakers. Thanks.
Steve, that's some impressive data that I think you've presented there. I'm particularly impressed and encouraged by a single-digit pacemaker rate. That's really encouraging. But I think that the people who have resisted transition to this always got worried that, well, if we implant the valve higher, we're going to get some pop-outs and we're going to see some more PVL, and really encouraging data that you're not showing that. This study comes with a particular algorithm in terms of post-procedural management of patients with conduction disturbance. Can you tell us a little bit about that, and whether you think it's the implant technique or indeed that algorithm that is resulting in that reduced pacemaker rate, that single-digit pacemaker rate?
Darren, that's a great question. And I believe that it's both, but I do believe especially that the implant technique, the REO cusp overlap technique, allows you to be very precise where you are landing on the non-coronary cusp. And that allows us to be relatively higher than we have been historically implanting. And so we interfere with the conduction disturbance less. On the other hand, better outpatient monitoring has helped us. We do use the algorithm that has been published in JACC Intervention by Dr. Rhodes Cabal, but I think there's a little bit more liberalization of who gets home earlier and who gets a monitor rather than straight to pacemakers.
That's great, and it's good to hear you say that that we're not implanting higher, we're implanting higher than we used to.
Yes,
because I think that's an important caveat here. We're still implanting this valve at 3 millimeters. It's just that we're sure that it's 3 millimeters and not 5. Doug, you guys have pioneered this technique in many senses. You've been using it for quite a while and had some great results with it in Manchester. Can you tell us a little bit about your clinical experience with this technique over the last couple of years?
Yes, thanks very much, Darren. Thanks very much for the introduction. Yes, we've been using the cusp overlap technique for a while now, and we've been interested in the anatomy, Darren, and basically when you come caudal from the 3-cusp view, which is what typically we had been doing, not only the right coronary cusp goes up, but the device goes up. And we believe that that's why the sort of traditional way of putting the valve in can also systematically lead to a low implant, because the valve looks higher than it really is, and that leads you to put it in deep. So we've been interested in the anatomy of it, but we've also been interested in the technique, the ease of the technique. And I really have to agree with Steve that isolating the non-coronary cusp just gives you that pigtail next to the valve and allows you to do a very accurate implant. So it's accurate in terms of the geometry, and it's accurate in terms of in the lab ease of use. And there have been some concern about the extreme angles that can sometimes be involved. We've looked at this as well. And the angles are not extreme in most cases. So 80% of cases there in blue are not an extreme angle. And when they are, you can have a look at your CT setup and choose a less extreme angle, still on that or very near that annular curve. So we think this is quite a usable technique, both full cusp overlap and then in a small number of patients partial cusp overlap. And these are our results, Darren. So we saw some fantastic results from Steve. These are our single center results. And we were actually managing to trend to a roughly 5% pacemaker rate, which was lower than Sapien in our series. So we're certainly very convinced by it. So yeah, is it standard of care? Well, for us it is.
So Doug, the cusp overlap is clearly standard of care in your center. How do you do it? From patient to patient, do you have variability in how you apply the technique, or maybe you could just take us through a step-by-step account of how you treat a patient using this technique?
Yes, sure, Darren. Well, it's pretty systematic. So basically, we have a good look at a CT scan. We get our 3-cusp angle. We get our cusp overlap view angle. If the cusp overlap view is extreme, then we choose a partial cusp overlap view using the CT. In the lab, we go to those projections, check that those projections are as they are on the CT. Sometimes it needs some adjustment, get our setup views, and then generally we cross the arch in the 3-cusp view. But then when we've come to the ascending aorta, we flip over to that REO caudal cusp overlap and then start sort of mid pigtail. Really important to get that pigtail right at the base of the non-coronary cusp. And then when we're flaring the valve, we keep that metal frame exactly at the bottom of the pigtail, or perhaps just below, which works out at 3 mil in most cases below the annulus. So we keep it there, we flare it there, we rapid pace, check it 80%, flip over to an LAO view, check it looks okay in terms of AR, in terms of the coronaries and LAO, and very slowly release. So really, we do that for all cases. It's our systematic approach, basically.
Great. It's interesting to see people, the return of rapid pacing while deploying self-expanding valves, just to keep it in the same position. We've gone away from it and coming back. Steve, do you guys do anything different in Columbus?
So the only things that I've learned to be a little bit different are I don't really go that rapid pacing. It may be 120 or 140, and I gear up the pacer and gear it back down when I'm deploying. When I go over to the LEO view, I never change the caudal angulation. And when I do the angiogram there, I'm really just looking to see where I'm going to land on the left cusp. And as Doug and I have talked about in the past, I really like the use of the double curve Lunderquist wire. I think it gives you exceptional control at the non-coronary cusp. And I believe that's the recipe.
Oh, that's great. It's great to hear you guys have two slightly different techniques, but are still achieving great results. Steve, when are we going to see the final results from the Optimize Pro? I know that there's a European arm that's been added on to the US leg of things.
The enrollment we anticipate for the US study will be done in the summer of 2021. The European arm is getting up and running, and that'll take a little bit longer, but I'm looking really forward to see that this technique can be widely adopted by everyone, as many in the EU have already done, and that we could replicate low single-digit pacemaker rates. We're trying to be as good as Doug. That's what we're trying to be.
We've all got a little bit of work
too much
to do.
Pressure, too much pressure.
I think.
Yeah.
I would say we pace right bundles, so that would take it up a bit if we didn't pace right bundles.
Okay, well, thanks for the honesty, Doug. Guys, thanks for the insights. Thanks for sharing your techniques with us, and Steve for the data. We look forward to more great data from you, Doug, and from you, Steve, for the final results from the Optimize Pro study. Thanks for sharing your insights, and I hope that you guys and the participants enjoy the rest of the course. So take care, and we'll see you again.
Thank you so much.
Thanks a lot, Steve. Thanks, Darren.
Yes.